Welcome guys to this video based discussion. So we have already covered Harrison in this Harrison based series about chapter 131 pneumonia. Now we're moving forward to lung abscess. That is chapter number 132. Now, before going into detail about this part, I would like to discuss about the current Harrison based revision program that we're going on, and we'll start with batch B. So this is a method to complete Harrison, whole Harrison, chapter 1 to chapter 505 in the form of weekly test and note. Okay, so link for joining the Harrison based discussion group is available in the description. Please click here if you want to join. Okay, so website and link is available. This is the complete schedule. We are starting from first week of July. So we'll cover 23 chapters each week followed by test. Target are obviously post MD or post DNB who want to complete Harrison as early as possible, or the resident who do not have enough time at their wards at their during their duty hours to open textbook or read even. So idea is that they can complete the topic in the form of question and discussion format. Okay, so this is our schedule for 6 month duration to complete the Harrison. So moving forward, so in MCQ mode discussion, thing that we're going to say about is that, so we are going to the lung abscess chapter. Few will look into few options and MCQs. So first question says, most common predisposing mechanism for primary lung abscess formation is. Okay, so from here we need to know the concept of lung abscess. What is primary lung abscess? What is secondary lung abscess? Okay, thing is that the term abscess, the term itself is abscess. So when there is infection in the lung tissue, when there is infection in the lung tissue, and this infection is not treated by any reason, it is not treated by any reason, it will lead to necrosis. So how do you identify necrosis? In imaging, you will get ER foci. So when you find ER foci, you know necrosis is taking place. And this necrosis will lead to formation of cavity. When this cavity gets filled with pus, and this pus-filled cavity, along with necrotic debris, has size of at least of 2 centimeter, it is considered to be lung abscess. So solitary cavity with fluid-filled pus in it is considered as a lung abscess. Okay, so this is the main primarily definition of lung abscess. Now, as you can see in the imaging itself also, so in the left-hand panel and the right-hand panel side, so here in this one, so here marked part, you can see there is some sort of consolidation in the lung tissue, along with, if you can observe clearly, there are marked ER foci present. So what does it denote? It denotes the stage of necrosis. Later on period, in the same patient, there is cavitation and specific ER fluid level. So this is cavity with ER fluid level. This is nothing but a case of abscess formation. So usually necrosis leads to abscess formation in later stage. Now this lung abscess is again classified into 2 types mainly based on the pathogenesis. So if patient himself or herself is the root cause of the disease, it is considered as primary lung abscess. So for example, patient aspirated food content or oral content inside and it gets accumulated in the lung tissue. This kind of event is known as primary lung abscess. Now, if there is disease, some infection or some foreign body obstruction or some malignancy which obstructs from within the lung tissue itself, it is considered as secondary lung abscess. All right, secondary lung abscess. Now, let's come into this MCQ. So first question says most common predisposing mechanism for primary lung abscess formation is, so we know primary really. So primary lung abscess is when patient himself or herself is the root cause of the problem. So there is aspiration. So aspiration for oropharyngeal content, option B. Option B will be the correct answer. Okay, so option B is correct answer here. Hematogenous seeding, as in case of malignancy or septic emboli, bronchial obstruction by tumor, or direct penetrating trauma. So when pathology originates from the lung tissue itself, these are all the secondary causes of lung abscess. Now, classically affected lung segment in aspiration-related lung abscess due to bronchial anatomy is. So we need to know a little about the structures here. Before moving to the structure, remember, primary lung abscess, it is the most common cause, 80%, develops in the healthy lung tissue. Mechanism is aspiration. So leading etiology for primary cause is aspiration of oropharyngeal content. Now, if I ask you, what will be that pattern of pathogen in case of primary lung abscess? So these, as these are oropharyngeal content, they will have anaerobic infection because commensals in the oropharyngeal airway as well as the dental cavities and everything in the oral cavity mostly are anaerobes. So in case of primary lung abscess, mostly what we see anaerobic infection. Now secondary lung abscess, it occurs due to blockage, neoplastic growth, inhaled object, that is foreign body, suppressed immune system, infected migratory clots. All of this lead to secondary lung abscess. Okay. So most common cause of secondary lung abscess is nothing but obstruction due to bronchial malignancy. Now here we need to know also the concept of acute versus chronic lung abscess. So anything which occurs within 6 weeks period is considered as acute in terms of lung abscess, and anything which occurs beyond 6 weeks it is considered as chronic presentation. So chronic lung abscess usually occurs when immunity is good enough in such patient. Immunity is good. Okay. All right. So what are the risk factor? So risk factor you need to know. For primarily it is aspiration and 80% of the cases are primary. So most of the cause of the risk factor of aspiration are the risk factor of lung abscess. So you can remember it with something which lead to increase in the event of sleep in such patient. So by the term sleep, you can remember it to be the mnemonic to remember the causes of lung abscesses. Okay, so what is meant by the sleep here? SLEE, sleep. Okay, so S here, S for is seizure, L is loss of consciousness, E is epilepsy. So you can remember S for stroke itself, another E for ethanol, and P is poor oral hygiene. Okay, so S is stroke, cerebrovascular accident, L for loss of consciousness, E is epilepsy, another E for ethanol, P for poor oral hygiene. So sleep is the mnemonic to remember the cause of aspiration in case of lung abscess. Okay. So high yield point, most significant clinical trigger is aspiration event. Now, I'm not coming into this part. Most importantly, when there is aspiration, this inhaled oral bacteria leads into lung inflammation, destruction of tissue, cavity development, and pus-filled cavity formation. Roughly, this period takes around 1 to 2 weeks. So this is one important MCQ point. From aspiration to pneumonia development to abscess formation, usually takes 2 weeks of period. Okay. Now, which is the most common site for abscess formation? This is one of the important MCQ question that you need to know. So, if this is your trachea, our right side of the trachea, so as you can see here, our right side of the trachea is more of a horizontal in nature, or more of it is in the straight line. compared to the left side when it gets divided. That's why any foreign body which is aspirated get easily dislodged in the right side. Okay. So which is the most common part it gets dislodged in the right side? It is the superior part of the inferior lobe. It is the superior part of the inferior lobe which is the most commonly affected. Okay. So right bronchus is steeper and broader, and that's why right-sided lesions are more predominant. So which one is the most common? So it is the superior segment of the right lower lobe. Okay, superior segment of the right lower lobe is the most common. All right. So as you can see here in the MCQ question. So classically affected lung segment in aspiration-related lung abscess due to bronchial anatomy is the superior segment of right lower lobe. Option B is the correct answer here. Now coming to the next question. Putrid, foul-smelling sputum in a patient with lung abscess is essentially pathognomic for infection with. So most of the cases of lung abscess is nothing but anaerobic infection, and it is due to the poor oral hygiene, dental cavities, dental caries. All of this content goes into the lung. This anaerobic infection leads to putrid and foul-smelling sputum. So most common cause here is anaerobic bacteria itself. Okay. So let's go to the next question. This is very important one. So, capillary lung lesion in a patient following solid organ transplantation should raise particular suspicion for which organism? Okay, so we are going to discuss about microbiology now. Prevalent organism is anaerobic. Among anaerobic, you need to know the name of Streptococcus, Prevotella, Bacteroides, and Fusobacterium. I will come about Fusobacterium, important point. Most common pathogen in primary disease is nothing but anaerobic bacteria, and it is around 80% of the cases. Now there is something is caused by macroephilic streptococci. So Streptococcus aeruginosus complex is associated with necrotizing pneumonia. This necrotizing pneumonia can further lead to lung abscess. That's why if question is asked, non-anaerobic most common bacterial cause of lung abscess, what is the most common cause? It is Streptococcus aeruginosus complex because it leads to necrotizing pneumonia. Okay. Among secondary lung abscess, which is caused due to lung infection per se, typically there can be aerobic gram-negative rods like Pseudomonas or various enterobacteriaceae or Klebsiella pneumonia. Gram-positive cocci type aureus can also lead to this formation. An important MCQ point for it is that frequent pathogen after influenza infection is Staphylococcus aureus. So what is the concept here? If there is MRSA, in MRSA pneumonia, usual empirical antibiotic doesn't work on it. Then this MRSA pneumonia leads to complication. This complication will be in the form of cavitary formation, cavitary pneumonia in future, and this cavitary pneumonia may lead to formation of abscess. All right. So this is the pattern in which MRSA leads to cavitary pneumonia and formation of abscess. Now, in immunocompromised host, the question that we are dealing with actually. So, in immunocompromised condition, we need to consider atypical organism. So, what are the atypical organism? It can be fungus, it can be nocardia, it can be microbiological species. So, fungal pathogen, what you need to consider? It can be aspergillus species or mycorrhizal species. Nocardia species, mycobacterial infection, we need to consider when the host is immunocompromised. Now, if there is cavitary lung disease, post organ transplant, first suspicion should be nocardia unless proven otherwise. So post organ transplant, which patient is on chemotherapy or immunosuppressant medication, they have low immunity, and if they present with cavitary lung disease, in such condition, thing that we need to consider is nothing else than we need to consider for nocardiosis. So option A here is the answer. Option A, nocardiosis. Okay. So next is about percutaneous or surgical drainage of lung abscess. So we are moving into the treatment methods of lung abscess here. So let's go into the treatment. But before that, one specific etiology I would like to discuss. It is known as septic embolic disease. So what is it actually? So understand this. This is superior vena cava and inferior vena cava draining into the right side of the heart. This is right atrium and right ventricle, and from right ventricle there goes the pulmonic circulation. So we are only dealing with the right side of the heart at this point. This valve is known as tricuspid valve, and this valve is known as pulmonic valve. In case of IV drug abuser, there is high chance of formation of endocarditis in the tricuspid valve because of the direction of the IV drug through IV pathway, through upper limb pathway. It goes into the superior vena cava pathway, goes into the right atrium, then right ventricle, the pulmonic circulation. So this is the normal usual pathway of circulation. So in case of IV drug abusers, there is high chance of endocarditis in tricuspid valve endocarditis or pulmonic valve endocarditis. So there is formation of thrombus along those valves in IV drug abusers. Now, what happens when heart is circulating? So, when heart is pumping, there is high chance some of these thrombus will get dislodged and follow the same pathway of the blood flow. So, some part of the clot will emboli with pumping action of the heart, and it will trace the same blood flow, and from tricuspid valve to pulmonic valve to the pulmonic circulation it will flow. It will flow until and it goes to the distal pulmonic vessel, and in distal pulmonic vessel it will lead to obstruction. It will completely clog the circulation, resulting into obstruction, and this condition will lead to septic emboli associated lung abscess. What important pattern we will see in case of septic emboli associated lung abscess? In case of septic emboli associated with lung abscess, you see only not a single pattern of vessel involved. It will be multiple vessels in multiple lung vessels. So there will be embolus. If you see heart margin in CT scan, there can be embolic phenomena, embolic lung abscess in multiple regions. So in septic emboli associated lung abscess, multiple region abscess will be present. Okay. So this is the concept you need to understand here. So septic embolic disease etiology can be tricuspid or pulmonic endocarditis. There is something also known as Lemierre syndrome. So you see there is a patient in intensive care to directly go and cannulate the central vein because usually most of the cases peripheral vein cannulation is not possible. But thing is that it should be always avoided whenever the condition is, because in case of central vein cannulation, invariably there is high chance of formation of thrombus. So thrombus, which you call it to be IgV thrombus. Beside Beside IV cannulation, these thrombus can also be there to poor oral cavity hygiene, which lead to oral cavity infection and thrombus in the IgV. These thrombus will also follow the similar route. It will follow the superior vena cava, which will go when it gets embolized. So superior vena cava, it goes into right atrium, right ventricle, pulmonic circulation, and ultimately obstruct the distal pulmonary vessel, resulting into septic pulmonary emboli. So thrombus in IgV due to infection in oral cavity, which get transferred as a septic emboli to the lung, resulting into multiple lung abscess as multiple site. As you can see here, at multiple site abscess is there. This condition is particularly given name of Lemierre syndrome. Okay, so septic jugular vein clot syndrome is known as Lemierre syndrome. Okay, all right. So this is one of the important concept block. So what are the usual overall presentation, clinical manifestation of lung abscess? Because it is abscess, there will be prolonged pyrexia history, productive sputum will be there, pain will be there in the thoracic region, and patient will have white loss and cachexia. You see, all of these are feature of mycobacterium tuberculosis. All of this can be feature of cancer too. So these two are the important differential of this case. One of the pathognomic feature, malodorous sputum or putrid expectoration can be seen in case of lung abscess because of anaerobic infection. So this is one of the MCQ which is solved currently. Sometimes coughing of blood can also be seen, which is also the feature of MTB or lung cancer. Okay. So what will be the finding in clinical feature finding? So as there is cavitation in the lung tissue, so consider this to be lung tissue and there is cavity inside which contains fluid. So when I keep a chest piece, auscultate, so whenever the sound moves through the trachea, through the lung tissue and goes into this fluid filled cavity, it will make a sound when sound passes through the hollow cavity. So it will have a higher pitch sound giving a pattern known as amphoric breath sound. Okay. So high pitched whistling sound when it passes through a cavity, it gives an amphoric breath sound. Now, if the tissue usually when is more superficial, it will give such sound. So when it is very much close proximity to the stethoscope, bell end, it will give such sound. When deeper, similar sound will be seen, but it will be little bit dull. So these deeper tissues will give deeper lung abscesses will give cavernous sound, whereas superficial one will give amphoric sound, bronchial breath sound on auscultation. Okay. What are the other thing you need to examine in such patient? Don't miss to examine the oral cavity because advanced periodontal disease can be there in such patient. Chest radiography is the first investigation of choice. It gives the idea of thick wall cavity with air fluid interference. CT is done when to enhance the sensitivity over X-ray to detect idle cavity, screening for tumor or distinguish from empyema. Okay, so we've discussed about differential diagnosis. Non-infectious causes for cavity along with fluid-filled cavity rather can be cavitating lung cancer, rheumatological nodule, or dermatosis with polyangiitis, another cause of cavitary lung disease. Lung disease. So, sputum culture is not usually useful in such cases because often provide false data due to mouth flora overlay. So, core reason for culture unreliability is contamination from oral flora. So, we don't know whether this is a true pathogen or false pathogen in such cases. Bronchoscopy is not indicated in all cases. It is only indicated when there is foreign body. We want to remove the foreign body because of the suspicion of foreign body, therapeutic indication of bronchoscopy, or we want to go for endoscopy or bronchoscopy guided biopsy because they suspect it to be malignancy. Okay. Or if there is inadequate response with initial therapy, which should cover anaerobic infection like anaerobic coverage, drugs with anaerobic coverage, it can be clindamycin. So if after initial therapy there is no response, we consider for bronchoscopy. So first line therapy, it is clindamycin. Clindamycin therapy is the first line. IV induction is done 600 milligram every 6 hourly. So clinda, C for clinda, C also look like 6, C for 6 hourly. Okay. So clindamycin 600 milligram 6 hourly. Then we convert it to 300 milligrams 4 times a day. 300 means the 4 times a day oral medication. Okay, so this is the gold standard therapy if monotherapy is asked. Alternate option, if clindamycin is not possible or clindamycin allergy is there, we can consider ampicillin sulbactam as an IV route and amoxicillin clavulanate for oral maintenance therapy. Okay, so favored beta-lactam combination is ampicillin and sulbactam. Another drug we can go if we want levofloxacin group, cephalosporin group, we can consider moxifloxacin because it is potent standalone antimicrobial choice of moxifloxacin. It has got broader anaerobic coverage. So quinolone, respiratory quinolone with choice for anti-anaerobic action is moxifloxacin. Also, it is also respiratory control of choice in case of CKD. Now, how long we need to treat? In case of pneumonia, we were treating for 5 days empirically. In case of this abscess, 5 days therapy will not work. We need to continue treatment minimum 3 to 4 weeks duration. Or there is resolution seen on subsequent imaging. Okay. Sometimes you may need to continue management even 2 months, 3 months, or 4 months in such patient, and sometimes they do not respond to treatment at all. So at this point, we need to consider when antibiotic fails, latent malignancy, obstructive object, or immune deficiency. So there can be hidden bronchial occlusion which lead to treatment failure. Sometimes abscess can be very large, so drug is not penetrating properly, so there is no response with drug. At the time, we consider surgical therapy. So abscess diameter more than 6 to 8 centimeter, symptom that persist, and indicate response to antibiotic, we consider for surgical therapy. So what are the complications of percutaneous drainage? Complication of percutaneous drainage involve pneumothorax, hemothorax, or pleural space infection. Complication of lung abscess per se can be resulting formation of abscess cavity with connecting duct known as empyema. It can lead to long-standing lung damage known as bronchiectasis, or abscess can recur in future too because these are very hard to treat because no drug can penetrate lung tissue, preferably such a good way. Okay, when there is cavity along with it. Severe complication can be massive pulmonary hemorrhage if that abscess cavity warns of the pulmonary vessels. So this abscess cavity, if it is very close proximity to the pulmonary vessel, it will start eroding the pulmonary vasculature, resulting in the severe and massive pulmonary hemorrhage. Okay. Similarly, as one lung is compromised, another lung is over dependent. So hyperexpanded lung, there is also chance of contralateral lung aspiration in such cases. So better prognosis in obviously in the most common cases, primary abscess is the better prognosis. Poor prognosis will be secondary abscess because in secondary we are talking about malignancy. Malignancy per se is always a bad prognosis. So this bad prognosis, if size is more than 6 centimeter, drug cannot penetrate properly, we need to give for surgical therapy. If there is associated bacteremia, aerobic blood infection, there is bad prognosis. Symptom lasting for more than 2 months, so drug is not affecting at all, bad prognosis. So tumor associated, so oncological causes, bad prognosis. So strongest negative predictive factor in such case of abscess is that whether it is primary or secondary, primary good prognosis, secondary bad prognosis. All right. Okay. So let's see few of the question again. So percutaneous surgical drainage of lung abscess is typically considered when abscess diameter exceeds it is 6 to 8 centimeter. So here you can see easily in this chest X-ray ear full cavity is present. A 50-year-old chronic alcoholic man. So alcohol is a risk factor. Slum area, poor oral hygiene, dentition is poor. Fever, weight loss, and cough producing foul-smelling sputum. So you suspect this to be anaerobic infection over 3 weeks. Chest X-ray showing ear fluid cavity. So it is nothing but, and it is in the right side lower lobe, most likely right lower lobe or the right upper segment lower lobe. It can be. So most appropriate first line antimicrobial choice here is, so we know first line antimicrobial choice is either clindamycin alone as a monotherapy. You can obviously go for fluoroquinolone choice as moxifloxacin monotherapy, or you want to transition to IV, you can consider ampicillin sulbactam. Then it can convert into oral into amoxicillin clavulanate. So answer will be clindamycin or ampicillin sulbactam, option A. Okay, so 35-year-old man presents with fever, neck swelling, and odynophagia. So there is oral cavity inflammation is there for some reason. That's why there is odynophagia. Maybe peritonsillar upset or tonsillitis. Followed by several days later by pleuritic chest pain and hemoptysis. CT neck shows internal jugular vein thrombosis. So here dealing with Lemierre syndrome, right? And chest CT reveals multiple bilateral cavitary lung lesions. The most likely diagnosis and causative organism area. So remember, in this imaging, you can see lung is not given, rather IgB has been marked. So most likely there is IgB, thrombosis is there. You can see a little bit of black area here. So most likely this is the thrombosed part. So blood flow is not complete. So most likely diagnosis here will be Lemierre syndrome, and Lemierre syndrome is caused by Fusobacterium necrophorum, which is nothing but anaerobes of oral cavity. So there is a child in rural India with poor nutrition status, developed lung abscess that failed to improve after 2 weeks of appropriate antibiotic therapy. So what you need to suspect when there is antibiotic therapy failure? You need to suspect malignancy, you need to suspect foreign body obstruction, you need to suspect in terms of surgical therapy. So bronchoscopy has been performed here. What is the most important condition to rule out in a child? In a child non-resolving lung abscess, cancer will be the second DD forming. First DD forming will be obviously foreign body aspiration causing bronchial obstruction. So 50-year-old smoker present with a lung abscess that doesn't resolve despite 4 weeks of therapy. So here, as you can see in this question, so there is no response with therapy. So there is risk factor. The risk factor here is smoker given. Alcoholic is not been mentioned. So which underlying condition must be specifically excluded as a cause of secondary abscess? So endobronchial obstruction malignancy at this age group, I would obviously like to rule out. 40-year-old male, poorly controlled HIV, CD4 count is low. Cavitary lung disease is there. Sputum surgery is a negative for AFB, so TB is the first thing that has been ruled out. Given its immune status, which additional fungal pathogen should be specifically considered alongside nocardia? Okay, so alongside nocardia, in such cases, I will consider it for aspergillus fungal species. Okay, so these are the another important thing which should be considered in immunocompromised patient. Okay, so that's all regarding lung abscess. Follow this YouTube channel for more such content regarding Harrison-based discussion, 22nd edition discussion. Once again, I am talking about this batch B, which is a question and test based discussion method in which we are going to cover the 6-month schedule for Harrison in 6 months. Who want to join can obviously join through the link provided in the description.